So good afternoon, ladies and gentlemen. It's my absolute pleasure to welcome you, both those here in the room and those watching this on either the live stream or the recording, to the Paediatric Advanced Life Support updates from the AHA and ERC for the guideline launch today. It's a fantastic day. My name is Dr. Barney Schofield. I am a paediatric intensivist from the Hospital for Sick Kids in Toronto. I am also the chair of the Paediatric Life Support Task Force for ILCOR. And we are going to be working through some hot topics and some key features of both the AHA and the ERC guidelines. Just a couple of kind of guides to the group as to how the session will work. We have Slido instructions for those that are watching online. We have our wonderful ERC young investigator, Aditi, who is watching the live Slido questions coming through. Unfortunately, you can't use it like a chat function. We have a limit to the amount of questions that you can pose, but if you put those, and then they can be put to the panel in the room. So we will keep an eye on that. As well as that, within the talk, as we go through, you will see that there are various sections that we will do, and after each section, there will be opportunities for some questions to the panel that come up, and we will allow those to come from the people in the room. Of course, those online, if you're stimulated to ask a question, we will bring them at the end of the session when we should have plenty of time for discussion. I get the real honor to introduce the panel that we have in front of us for amazing clinicians, researchers, hard workers who have, over the last number of years, both added to the literature and resuscitation science, as well as pull it all together for these wonderful guidelines, which we're now about to present. From the European Resuscitation Council, we have Jimena de Castillo from Madrid in Spain, and Jana de Jakov from the Czech Republic. And from the American Heart Association, both Alexis Tobjan from the Children's Hospital of Philadelphia and Javier Lassa from Southwestern Medical School in Dallas. The disclosures are up here. In essence, the main disclosure is people have worked extraordinarily hard to present these. No one has had really any financial input or input, but from the point of disclosure, here we are. As I said, the outline of the talk that we currently have for this session is that we are going to present a little bit about the background about ILCOR and about the process of ERC and AHA. We will go over those fairly quickly as we've already had the main plenary session and you've heard from the main writing groups. We're then going to run through 4 key topic reviews: airway management and ventilation, adrenaline and shocks, in relation to the timing and dosage, monitoring and CPR quality, which has been some great new inputs into the guideline, as well as post-resuscitation care. Neuroprognostication is a new topic along with survivorship, and we're going to spend a bit of time at the end, and then we will have a summary and recap. And like I say, after each of these steps, there will be opportunities for some questions to the group. CPR guidelines have been around since the 50s and 60s, and there are some amazing kind of giants in resuscitation who started this process to discover that if you teach clinicians, if you teach the public how to do resuscitation, outcomes improve. And we are part of that journey now in 2025 to lead through and to be able to do that. And both in North America and with the AHA and with the European countries, these have been emboldened and improved and built upon, and it's great to be able to see that now. From the Peter Safra and the original kind of CPR guidelines, everything's been kind of iterative and built upon that, and it's great that we've been able to move through. The European Resuscitation Council was set up back in 1988 as part of all the 33 member councils and the national resuscitation councils across the countries. The American Heart Association, in a similar combined endeavor, worked together to bring the guidelines to us with various iterative improvements and kind of repeated guideline releases up until this modern day. ILCOR was explained in detail in the other session. ILCOR is the organization that allows the research to be evaluated with a kind of global view. Of course, we want to save more lives through resuscitation, and within ILCOR we have a paediatric task force as well as the other task forces that look at paediatric evidence to help try and improve the lives of children, and the focus on the way that both resuscitation and children are the kind of main and center focus. We have member councils that all feed into this process, and we have a task force with representations from those councils. So both the evidence evaluation and the consideration of how to try and give recommendations and treatment recommendations to those councils is kind of part of that iterative process. Of course, what we're going to have today is how the American Heart Association and the European Resuscitation Council have taken the evidence that has been produced from ILCOR and additional evidence that they've gone out to discover. Just about some of the processes, again, this was beautifully described earlier. The European Resuscitation Council has a very clear stepwise approach to both the way that questions are selected and how they involve public, both open review of the scope of what the guidelines are going to be, as well as looking and getting comments on both draft guidelines, as well as the way that the publication was put out there for further public comment, and that's both professionals as well as lay members of the public to be able to input. And there is a very vigorous peer review and steering committee approach to ensure that the guidelines, which have released literally minutes ago, are at the standard that they are. ERC scope is slightly different to the AHA. In essence, we have the elements of prevention, we have the pediatric advanced and the kind of basic life support approach, as well as looking at post-resuscitation care, special circumstances, but with a real emphasis on systems of care implementation, education, and approaches on kind of resource and low-income countries and lower resource areas within the kind of ERC remit. There's an interlink between, and I think one of the things that I hope that this session today will identify is how closely together ILCOR and the ERC and the AHA have kind of connected and shared and worked together to develop the guidelines. They're developed for different areas of the world, but actually the teamwork that's happened, both the sharing of information, the development of those processes. And back here, that's the step of actually working out what are the questions that people want to answer. ILCOR has its limitations as to how much evidence can be reviewed, and we take the questions that are being posed to us, but also the ERC and the AHA have been able to have their own processes of evidence evaluation for additional areas of the guidelines that they need questions or to identify where there are gaps. The AHA have a slightly different split in that there is a pediatric life, the basic life support and the advanced life support kind of chapters and working groups are separate. There is a separate session for the basic life support presentation, and so in a way the AHA have that and the ERC have split themselves with their chapter. Similarly, the AHA has again a very rigorous both overview of the process, the questions, the publication, the review, the oversight, through to the point of publication. A huge amount of work, but what it allows is a kind of high quality to deliver that. And again, a slightly different structure, but the interlinking with ILCOR about the questions that are generated. What is the questions that need to be answered? ILCOR takes those on if they can. We answer what we can and then hand them back to the AHA. Similarly, the AHA has its own rigorous use of librarians, evidence evaluation, scientists, and process to be able to look at that evidence too. So we get to the key topics, and it is my pleasure to hand this over to Javier. Is going to take the first section.
All right, good afternoon, everyone. Hopefully you can hear me. Before we get started, I really feel it's important for me to recognize my other co-chairs here, as well as the ERC team. Dr. Alexis Topshin here to my right, as well as many of the writing group members that are hopefully checking in online right now. Really thank you for all the time, energy over the past 2 years you've spent in putting this together, as it really was an incredibly rewarding, challenging at times, but equally important process for us. I sit as the AAP representative, and this is the first time that the American Academy of Pediatrics has joined forces with the AHA. This has been a joint effort, and so on behalf of the AAP as well, I want to thank the AHA for their partnership in putting together these guidelines. As Barney said, we will be taking a sort of categorical approach to this discussion. We've broken the guidelines into 5 main categories. As you'll see, we'll be talking about airway and ventilation. We'll be then talking about adrenaline and shocks. And with each section, we're going to make sure we have an opportunity for the audience to ask questions, both online and in person. If you are here in the room, please introduce yourself, because it is an intimate group. I think that'll make it even more important for us to know a little bit more about each other in this resuscitation community. And so with that, the clicker. Thank you, Barney. Me and Jana are going to be sharing right now a little bit of the discussion that's more global presentation in terms of how we've framed the pathway and the chain of survival for both groups. And so with that, I'll turn over to Jana. She'll tell us a little bit about the PLS chain of survival.
Okay, so again, I just want to thank on behalf of the ERC writing group for pediatric life support as well, all the co-authors. Maybe they are also checking online, and I think they did a marvelous job when we were putting these guidelines in life. So we would start with a chain of survival. First, I think it's great that we now have a universal chain of survival, and that's, I think, both true for ERC and AHA and AAP. I think it represents really all the patients now, and it was also difficult to establish how it will look, but I think at the end we are happy that we have a universal chain of survival.
And this is equal for the American Heart Association, the AAP. This is the first time that there is a universal chain of survival, and we've adopted a lot from our colleagues across the pond. The universal chain of survival applies to, again, in and out of hospital arrest, to both pediatric and adult, but does not include neonatal. There's a separate neonatal chain of care that you guys heard about today in the plenary session. From beginning to end, trying to modernize and make sure that the iconography is also important. I know that there was a lot of time spent on the ERC side in terms of making sure that the icons represented some of the important elements in terms of the chain of survival. And for us, we really wanted to make sure that the pediatric focus on airway and ventilations was included, in particular in that second icon, which is referring to high quality CPR. And so including the lungs in addition to the hands was a really important part of the 2025 effort. Moving on. Our algorithms.
So for the ERC, we didn't change that much in the algorithm. You can see that it's much nicer than the previous one, of course. And now we are really getting back to basics. We want to make it quite simple, and we have a lot of additional remarks that are below the original algorithm. And these remarks are also very important. What we added, and that's very, very important for the pediatrics, is to remember correct the reversible causes as you go through this algorithm. So that's the arrow on the left side, as you can see it. So that's important in pediatrics for ERC. And there's a lot of small remarks at the below the algorithm, which will explain some of it. We will also touch during this talk later on.
Thanks, Jana. I think I'd emphasize that there is so much more we share than differ in terms of both groups. But it's also nice to see a fresh and different approach to how to share the information. And so we've learned from each other. On the AHA and the AAP side, the formatting really remains the same for 2025, and the algorithm remains relatively the same as well. We have tried to simplify some of the language surrounding high quality CPR, which is that top gray box, as well as the medication boxes. However, the overall pathway and recommendations for either shockable or non-shockable rhythms remains the same. With a shock-epi approach for shockable rhythms and early epinephrine for non-shockable rhythms. And so let's go ahead and jump right into the first section. We're going to be first discussing airway management and ventilation strategies. And so we're going to tackle these sections again as a duo. You're going to see sort of all four of us speaking, but we do want to frame each section with an important vignette. That's what that top gray section is. You're going to notice that there's 3 unique columns for a lot of these boxes. The first column on the left is the specific topic, and then whether or not the ERC and the AHA recommendations are aligned will be represented as a merged or single box below that, as you can see here for this entire box. So these are sort of shared guidelines between our groups. And you'll see in other areas we may have slightly different, and those will be highlighted. So you'll be able to see where there's similarities as well as where there's differences. And so with that, I'm going to tackle this first one here, and I think I want to frame this and get everyone in the room and online to try and understand where we're going with this. And so you're caring for a 6-year-old in cardiac arrest who's got poor chest rise with bag valve mask ventilation. And so what's the next step? And so when it comes to a preferred advanced airway, both groups are recommending either endotracheal intubation or supraglottic airways if a trained provider is available. And again, bag mask ventilation is still okay for both in and out of hospital cardiac arrest, but if you have trained providers available, both ET tubes or supraglottic airways could be used. When it comes to ventilation rates, avoiding hyperventilation is our common plea for the lay and the health care professional communities, targeting normal carbia with normal PA CO2s in the 35 to 45 range. And then when it comes to end-tidal CO2 monitoring, this is an important tool to verify the position and placement of an endotracheal tube or supraglottic airway. It also can be used to assess CPR quality and detect ROSC.
So if we are caring for a 6-year-old in cardiac arrest who is now intubated, which can happen either during the cardiac arrest or he can be already intubated before the cardiac arrest. The question is how you ventilate. And the ERC, there's actually no specific evidence to look at how the ventilation rates should be. And the way we look at it is we looked at the normal range and we rather put it a little bit at the lower end of the normal range for this age, just to avoid the hyperventilation. So that was our thinking in the ERC, and we put there a specific logical rates that we would probably use for specific age groups.
And as for the AHA, if an advanced airway is present, we're recommending similar guidelines to the 2020, which was to give breaths every 2 to 3 seconds. And that's really important for patients, especially those greater than, for those greater than a year of age.
So when we look at the 5-year-old cardiac arrest patient who is being monitored with ETCO2 during CPR, which is what we both recommend. The ETCO2 values are fluctuating between 5 to 10 millimeters of mercury, and the chest wall rise is poor. So what do we recommend at the ERC? We actually say that when the ventilation is ineffective with advanced airway, you should go back to revert to 15 to 2. And as it comes to the ETCO2 cutoff for termination of resuscitation, this topic is mainly covered in the ethics guidelines, but we say that we should not terminate the resuscitation just based on the ETCO2. That's probably similar.
Yeah, we would highlight that in this vignette, the patient is intubated. And so that's important to recognize depending on whether they're intubated or not. In general, when it comes to using end-tidal CO2 for termination of resuscitation, should it be used to assist in the decision-making for terminating the resuscitation? And we've emphasized pretty strongly in our guidelines this year that a specific end-tidal CO2 cutoff should not be used, given current evidence that supports many patients who have survived, and greater than half of the patients with end-tidals less than 20 or even 10 have gone on to achieve ROSC. As for reverting to 15 to 2, again, it depends if there's an endotracheal tube present or not. If there is no endotracheal tube present, we recommend 15 to 2 always for prepubertal patients when you have 2 rescuers. Otherwise, if the patient is intubated, we will continue to recommend the 2 to 3 breaths recommendations we have right now are 20 to 30 per minute. And so, in summary, An endotracheal tube or a supraglottic airway is both safe if there's a skilled provider available, and again, this is shared between both groups. We both feel strongly that we need to avoid hyperventilation, and end-tidal CO2 monitoring is essential, but should not be used, a specific cutoff should not be used for termination of resuscitation. So with that, we'll
Thank
pause.
you. Yes. So we have an opportunity for any questions within the room to ask on this first section. Just in case anybody is thinking now that they're part of the conversation, I was going to just put to the two groups. Within the recommendations, the idea of the kind of provider skill and the training is kind of inherent in the decision making. I just wondered within the working groups, through the conversations that came about, how you considered the kind of training models and the way that people may be trained in your regions and how that may affect these guidelines, knowing that, for example, respiratory therapists may be available within the North American setting, in the AHA. Across Europe, we have 33 different countries with different training systems. Was there any consideration or kind of nuances to how training was part of that?
Well, as for the ERC, there were some discussions about whether we should define the level of training, but because there are so many systems in Europe, it would be very difficult, and we just kept the word that the person needs to be very competent in this skill, and we all know that the pediatric intubation is a skill that is not easy to achieve and it's not easy to have still if you are not doing it on a regular basis. So that's our main thing, and that's why we also say if you are not competent, just rather do what you are competent with. So if you're skilled with supraglottic airways, do supraglottic airways rather than to intubate if you did it only twice in your life.
I think we follow a similar line of reasoning in terms of our approach to the North American training opportunities. We kind of, in some ways, break it down to the pre-hospital and then the in-hospital settings in terms of training. We know that EMS providers are uncomfortable with children, and so I think it's really important for us to be able to highlight the fact that bag mask ventilation as well as either supraglottic and endotracheal tubes can be used. Again, going to what you're best at, especially for adult providers in an emergency room setting who may not see a lot of children. I think that's the key thing we were thinking about when coming up with these guidelines, as well as making sure that the science was robust enough to be able to make that recommendation.
Thank you. Are there any questions from the room? Please introduce yourself. Thank you.
Hi, I'm Jean from Singapore. Nice to meet you, Jenna, again. Okay, just a question on end-tidal monitoring. I do know a lot of places, EMS systems, use colorimetric or semi-quantitative. And if we are looking at numbers, what are the implications? Are we advocating not using colorimetric or? Well, I'm just thinking about implementation science, right? So you have the science there, which is great, but then there's the intermediate of colorimetric end-tidal capnography that is in existence, which is much, much cheaper than most of the portable ones, the quantitative ones. So I'm thinking in terms of where does that place colorimetric capnography then?
Well, as I can say that we mostly thought about wave capnography because it gives you much more information than just a simple colorimetric. But to be honest, we didn't look at the colorimetry at the scientific level if there is some evidence or not. So we just basically, and in Europe, most of the EMS systems are now getting the wave capnography, so that's why we are mostly talking about wave capnography.
But Jean, can we clarify the question? Are you referring to confirmation of an advanced airway, or are you talking about monitoring CPR quality? Because they're very different questions.
Agreed. But as in end-tidal as a recommendation in cardiac arrest, for example. So confirmation-wise, I'm not too sure as well that the colorimetric is sensitive enough to pick up endotracheal confirmation. And it seems that this pertains to specifically quantitative or waveform capnography. I just little minor points where people buy into systems, how this might change things. I mean, coming from a practical point of view, a lot of the pre-hospital systems are getting the calometric, which now might think otherwise. Sorry, it's not an easy question.
He's just given us something to do for the next 5 years.
Exactly, yeah.
Yeah, I think the literature for the purpose of this reviews were waveform capnography with an absolute number. And I think we just need to be really thoughtful if we're going to go to calorimetry or try and mobilize that to really think about what we're doing with that and what that means, since it's really looking at an absolute number and is variable based on size, minute ventilation in those patients, as well as perfusion, obviously.
Thank you. So we're going to move on to the next section, and it's handing back over to Javier.
All right, moving on. We're going to be speaking about adrenaline and shocks, epinephrine for our folks in the back in the U.S., timing and dosage. And so for this next question, we have a 6-month-old who's status post heart surgery who develops pulseless ventricular tachycardia. And so when do you administer adrenaline in this case?
So for us in the ERC, we would say that to give adrenaline, and we made it to put adrenaline in rather than epinephrine in the slides. Yeah, it's not that. That we will say give adrenaline immediately after the 3rd shock, and or after the 4th minute, taking into consideration that we consider that the first shock is minute 0.
Yeah, so essentially we're quite similar. So we also state that it's reasonable to administer epinephrine, adrenaline, after 2 attempts at defibrillation. So again, shock, epi is still the mantra for us, and that hasn't changed from 2020.
Yeah, and I think we both agree still that in non-shockable rhythms, we should administrate the adrenaline as soon as possible.
Yes, emphatically, as early as possible. Now, when it comes to the next questions, the same patient who's just had heart surgery and developed pulseless ventricular tachycardia is now unresponsive to that first shock. What do you do next in terms of a defibrillation dose adjustment?
So we have not changed our past guidelines and the past recommendation, and we are still sticking to 4 joules per kilo on the first dose, and to escalate on subsequent doses up to a maximum of 8 joules per kilo after the 3rd shock.
And how we have also not changed our prior guidelines. Again, 2 to 4 joules per kilo is the frame or the range that we recommend with the first defibrillation dose at 2 joules per kilo. We can talk some more about that in terms of a recent study from Derek Hoyam and the Americans Get With the Guidelines Resuscitation Registry. Our maximum is 10 joules per kilo. Again, this is based off of both animal and human studies in terms of safety of the larger dose. And with that, I'll turn it over to Jimena for talking about sequential and stack shocks. And again, the definitions are there for the audience.
Yeah, this was a tough one, and we really discussed it a lot because we had different scenarios to contemplate. And even though there's no real evidence to support stack shocks, we thought that the scenario was merited merited us to contemplate this, and to say that even this is based on expert advice, it's not based on the evidence, and to say that when the patient is already monitored, the pads are on, and the rhythm is a shockable rhythm, you can give the 3 stack shocks, so before starting CPR.
We, on the other hand, did not feel that there was enough evidence to favor stacked or sequential shock. Sequential meaning you're using 2 separate defibrillators, maybe with an altered vector, given the quite limited literature, and so we still favor single shocks with the intercurrent CPR versus the sequential or stacked shocked approach. And so in summary, for non-shockable rhythms, and this is an important 2025 change for us in terms of breaking things down, at least on the AHA and AAP side, but for non-shockable rhythms, adrenaline or epinephrine, ASAP is important. As for shockable rhythms, rapid shock is still the priority. We have not wavered from that, the importance of making sure you're recognizing a shockable rhythm and then putting pads on and shocking as soon as possible, starting with a 2 to 4 joules per kilo dosing range with a plan to escalate dose up to a max adult dosing. And again, administer adrenaline if defibrillation is not immediately possible. Barney?
Thank you. So this was a great topic area from the kind of ILCOR evidence evaluation to try and give advice and to look at the evidence, particularly to do with the kind of first shock delivery, whether it's 2 joules per kilo or 4 joules per kilo. Jason Ackworth has done a great review of the evidence, and it was hard. And in essence, because there are no real direct randomized trials to say you start with 1 joule per kilo versus the other. However, we have 2 huge continents that have taken different approaches through the history of the kind of guideline development. So the answer is probably out there to try and help us, but the kind of ILCOR recommendations was that either is acceptable for it to be used. And this is kind of a difference that has come out within the guideline writing groups. However, they've remained consistent with the messages that they've continued to give over the time. And perhaps my question to the group is around that kind of context importance about what has come before and how that may change the recommendations or the way that you may have enough weight of evidence to kind of push the guidelines in a different direction if we can't give you the evidence from ILCOR, but what has come before within the kind of training programs over the last 5, 10, 15 years. So I just wanted to, that kind of conversation about what has come before and how that influences how you decide on your decision.
Yeah, and I think it's a valid question, because it's true that the evidence, going through the evidence, that both ratios of doses for the defibrillation were valid. And there was none was superior over the other, and there's arguments in favor of using 4 and in favor of using 2, and both were contemplated. But for us, it was an implementation issue mostly. So the changing the recommendation to be so that it was the same as the AHA will meet with changing all our educational program in around Europe, which implies lots of negotiation with lots of countries and trying to change all the resources regarding training. So with no more evidence to support such a huge change, we decided to keep things as they were.
It's not a surprise to me and probably to Alexis as well that the questions that have come up so far here relate to implementation, right? And so the linkage between evidence review, evidence-based guideline creation and how we deploy is absolutely important. We are learning how best to link the two. As you guys probably know, on the American side, we have 2 distinct groups within the AHA. One focused on reviewing the evidence, coming up with guidelines, and there's a gray wall that sits in between the implementation in the educational materials team. And so this is something we're still working through on how to make sure that we're partnering better. I will say that when we were going through the process the past 2 years, it was overwhelmingly important for us to think about harm more so, well, as equally as benefit when thinking about changing guidelines like this, because we know that people have been taught for a long time, probably on the ERC side and on the European side, 4 joules per kilo you start with, right? How long have you been teaching that? For many, many years. And while we've been teaching 2 joules per kilo for many, many years. And so we know that that's ingrained in a lot of the educational process and a lot of sort of the current junior, mid-level, and senior level sort of practitioners. So we always thought, if we're going to make a change, is there evidence not only for benefit, but is there also evidence that there's harm, and therefore we need to change? And so for us, we didn't feel like there was strong enough evidence to support going to 4 joules per kilo because of either there was harm from doing too little or harm from too much, and so that's why we've kept it where it's at.
We need a randomized controlled trial, and we need to recruit like 2,000 patients.
I would just say that this is an area where we've been using older data for quite some time, and to make a change, we're going to need some new research out there. So I think it's incumbent upon the researchers in this room and in the broader community to start answering these questions for us, so that if there is a better way for us to be saving lives in this scenario, we can go ahead and change the recommendations to do so.
A great call to arms. And Jessica, I think we have a question at the back, if you may.
Thank you for the presentation of the topic so far, Stefan Katzenschlager from Germany. I have a question on your 4 minute for the ERC, on your 4 minutes of the first adrenaline dose in shockable rhythm. In the flowchart, you say it's after 4 minutes. When do you start the clock? Or when should providers in a scenario should start the clock? On arrival, start of professional CPR, rhythm analysis after the first shock, 4 minutes after the first shock. And I know that in the text it says after the third shock, then...
Yeah, we considered that the first shock was minute 0. So that it should start at the first shock to quantify for adrenaline administration.
First shock is minute 2?
No.
No.
First shock is
0.
Is the baseline.
Okay, so
it's the
we start
baseline
the
of
clock
resuscitation
at,
in shockable rhythms. That's
okay.
how we consider it.
Okay.
Janice Tyson from Heart and Stroke Foundation of Canada, AHA and ILCOR. But this is a question for ERC, for the algorithm. Just the way I'm seeing it, if you go down the shockable route, how do you ever access the adrenaline dose if you're looping through on the left side of the algorithm?
Well, that's basically what you have in there for shockable rhythms. You have a specific text afterwards.
Oh, it's too small for me to read.
Yeah,
okay,
so
it
that
says
you give IV-IO adrenaline after 4 minutes, every 4 minutes thereafter. Perfect. So you have it there for shockable rhythms.
Hi, Michelle from South Africa. I just want to clarify, it's also for the ERC based on the stacked shocks. I assume it's a historical thing that's been happening. Is it something that is it just the initial shock, which is a stacked shock in a VF? And if so, have they considered the hands-off chest time sort of thing for providing those shocks instead of providing CPR?
The second question, what was it? I didn't catch it.
It's just about considering the fact that you're now doing shocks instead of doing compressions, the delay.
I mean, as the way we phrased it is in certain scenarios, like children in the PICU, children in the OR that already have the pads on, and in that sudden moment where you're assessing the child's health, you see a shockable rhythm and in the context of cardiac arrest. So while you are getting ready to start CPR, you can provide the 3 stack shocks to try to revert the rhythm.
So the first time.
Yes.
The first time.
And that's basically also ingrained a little bit on historical context, because a lot of providers who are in cardiac units, pediatric cardiac units, are doing this. And that was in our previous guidelines, and we kept it because people who are dealing with the cardiac patients are doing it this way. Although there was no evidence in either way to go, like for or against the stacked shock.
Another great example of questions that we need to answer more research for. You'll be pleased to know there's a key gaps slide right at the end in case you are a researcher watching this so that you can focus. But we're going to move on to monitoring CPR quality, and I'm going to hand over to Jimena.
So here we are. If you're caring for a hospitalized patient with an indwelling arterial line, what blood pressure should you target during CPR? And this is a specific quality measure. We both agreed that we should target at this diastolic blood pressure in this kind of patient and target 25 millimeters of mercury in infants and 30 millimeters of mercury in children age 1 to 18 at least.
Yep, and then as for a similar patient who's you're resuscitating in the hospital setting, when should you perform an echocardiogram or point of care cardiac ultrasound? And we both agree that it should only be used by trained providers and should not ever interfere with chest compressions. We all agree that echocardiography, specifically POCUS, and cardiac-specific POCUS, can be helpful to identify reversible causes, but again, always with consideration for balancing against the risk of chest compression interruptions.
And we wanted to look at an infant in terms of seeking CPR guidance and laboratory testing, which available feedback devices were safe and effective, and if we could focus on any lab tests to consider. So from the ERC point of view, regarding feedback devices, we couldn't find any evidence to support a specific recommendation on feedback devices, but we contemplate the incorporation of the CPR coach into the code team in order to provide for quality CPR. And as for point of care blood analysis, we recommend to check at least for those that can make us think of reversible causes like glucose, potassium, hemoglobin, lactate, and blood gas analysis, and just taking into consideration that this might be reversible causes, treat them as appropriate.
Thanks, Jimena. Yes, we also agree on the use of feedback devices, and this is not just for training, as was discussed during the plenary, but we do feel it's reasonable for feedback devices to guide compression rate and depth in infants and children. As for point-of-care blood analysis, this is not something we looked at in the current 2025 guidelines, but will be added to our list for 2030. Notable is the CPR coach, which we believe we have in another chapter of the overall guidelines that were published just several hours ago, but was not included specifically in pediatric advanced life support. And so, in summary, the arterial line in place patient, we should be considering diastolic blood pressures to assess response with a target of 25 millimeters for infants, and this is up to 1 year of age, and greater than 30 for children and adolescents. And again, pediatric specific point of care ultrasound and especially cardiac POCUS should only be used by trained professionals and without compromising chest compressions.
Thank you. This is a great area where pediatrics are leading the way to our adult colleagues and the kind of physiological guided responses. One of the challenges, though, is that there's quite a lot of caveats. You need an arterial line in place if you're going to do echo or ultrasound to either diagnose reversible causes or look at kind of progress or physiological changes during cardiac arrest. You need the resources and the settings. And, you know, the opportunity that you've already put the arterial line in the child before the arrest has happened. I suppose that the kind of provocative challenge to the two groups is if you're going to ask people to increase resources or develop technology that allows us to get an arterial line in a child receiving CPR, where do you think the best benefit from these things is going to come from? And how can you kind of advise the teams who may have resource limits about what they should be doing for these patients? Should you put all arterial lines into anyone who is on a ventilator in an ICU? Should everyone have POCUS training and ultrasound next to their beds? So I'm being slightly provocative about the limits to where you can go with these recommendations.
As an intensivist, I think I want it all. Because you really can't improve what you don't measure, to use a cliche. But I think it's a challenging question, honestly, Barney, because it's not only resources, it's the training component, right? And so placing an arterial line in someone who's receiving active CPR isn't easy. And so I want to highlight a piece that, PALS doesn't spend a lot of time on, which is prevention. So in those moments, hours, potentially days before an arrest, what should we be doing to think and potentially anticipate the arrest patient, who then you might want to think about putting an awake art line in, or getting your monitoring. And so this goes back to the call to arms that Alexis made, which is this is an area that is ripe for questioning. And so we definitely need a lot more information in order for us to make stronger recommendations about the use of arterial lines, which would maybe even extend outside of the ICU environment we're so comfortable in.
Yeah, and I totally agree with Javi, but I think with these recommendations, we acknowledge that the evidence says, or the evidence we can get hold of says, that if we have an arterial line in place, we have to target those values. And this, for us, is new because we didn't include that before. But on the other hand, we do recognize that the places where we are resuscitating our children are very diverse. The resources they have are extremely different from one to another, and the realities throughout the European countries are not homogeneous, but they're quite heterogeneous. So we are not recommending to put an arterial line in every child who has a cardiac arrest, even though we have a very extensive chapter on prevention of cardiac arrest that we really fought to have there, because we, as Javi says, consider that that's the most important part of treating cardiac arrest, preventing it.
Thank you. We have a question in the room. And just while the microphone's being put over, just to confess to the audience, none of these questions have been pre-posed to the panel.
Alan Decon, Heart and Stroke Canada, and Stollery Children's Hospital in Canada. I know, and I'll get ERC to comment after, because I'm not aware of how much they've dug down into the end-tidal CO2 targeting during chest compressions and using it as a target. I know there are authors in the room that actually put through presented data about targeting higher end-tidal CO2s than traditionally we had in the past as a marker of CPR quality. And I'm interested, and I guess I'll push this to the AHA folks first. Was I know that you folks had reviewed that literature. Is the feeling it just was not strong enough to actually say, let's push for a higher end-tidal CO2 target, or were there other reasons why it was actually not moved on as a reason to actually push the needle, raise the target?
So I think we looked at end-tidal CO2 from two directions for the purpose of this. One was for quality monitoring during resuscitation, and one was, is there a threshold where you should be living? And the data sort of broke out for, when you look through it, there were not numbers that were actually definitive enough for us to say absolutely where to go. So when you look at the actual recommendation in the guidelines, it's a 2B BNR saying that if you have an invasive airway, you may consider monitoring CPR quality using end-tidal. And as we've marched many of these guidelines forward, I'll say for diastolic blood pressure, it used to be you can look at diastolic blood pressure, there was not a number. This iteration, we finally got to a number. End-tidal CO2, not sure enough as to what number to give you. The data's just not strong enough. What the data was compelling was that it is not strong enough to actually terminate resuscitation. One paper that showed we had return of spontaneous circulation with end-tidals that were less than 10. And so we felt very strongly we could not give reliable numbers in either direction for people to use. Now, in the future, just like we've done with DBP, we may have those numbers, but we're going to need larger studies. It's going to be thematic, right? Larger studies, multi-center, to answer these questions prospectively.
Hi, Gene again, so sorry.
And just to follow up, Alan, I think for the audience sake, you mentioned historical numbers and that their recommendations maybe should be higher. Can you just inform the crowd in terms of what those historical numbers were? Because we're just to get out there, we're talking about 20 millimeters of mercury, right? In terms of sort of a number that has been put forward. We have a lead author from a multi-center paper and analysis here, Ryan Morgan. And so, 20 millimeters of mercury is what sort of is currently as potentially associated with ROSC, although overall survival not associated. So what were you mentioning in terms of historical numbers being lower?
And recognizing, and I'll be very, very brief, it's extrapolated from adult out-of-hospital data, very actually think it may have been for the Czech Republic, but it's actually 10 to 15 as that target, right? And we never really had data. And I know that, yes, it is in hospital, but, the ICU resus data that Ryan was involved with does suggest higher. But I very much respect that what you guys are saying is, yes, interesting data, not enough to move the needle yet in terms of changing the target.
Sorry, Alexis, I'm going to target this question to you. And I think we did discuss this before. With chest compression quality, when you have a target with CPR feedback, as an intensivist, I'm not, so I'm an emerge guy, it's easier for me. So you have the feedback machine, tells you the depth, quality, and then the blood pressure. So I'm going to put you the dilemma now that if you say that, then do we target the diastolic blood pressure, or do we target quality of CPR as determined by the depth and rate?
It's so funny because we had a case like this about 6 months ago. So I think it is not entirely clear. I would defer to Ryan, who knows this data way better than I do, and I think different people in our clinical practice do things differently. I think many people in our group, if we have the arterial line, are going to follow the arterial line. I have been surprised by the feedback devices in terms of where the pads are, how the bed moves. Sometimes we get these depths that are very shallow. Sometimes they're actually ridiculously high, and you're still not getting the blood pressure you want. So I think if we have an art line, we tend to use in our practice the DBP because it really is the output, whereas the machine is just measuring sort of what you're putting in. But oftentimes, if you don't have an art line, you're probably going to use the device. I think as this adapts into practice, we'll have to see how how that depth correlates with the blood pressure. I will just want to note that the DBP studies are out there only for the first 10 minutes of CPR, and so I think we need to be really careful as we extrapolate that into longer durations. We just don't know yet how that bears out. There is some data that will be coming, but this is really only in the first 10 minutes of CPR with an arterial line.
Yeah, just just a very short comment that when you have a diastolic BP, sometimes it's not only about the depth, but you move your fingers just to 2 millimeters left, and then you have much higher diastolic pressure. So it's not only about the depth, so it gives you another specific information.
Question at the back, and then we will move on to the next section.
Brief question. Emery Gagarian, SickKids Toronto. Is the word trained deliberate to be general, or did you shy away from competent in the POCUS use?
Given the lack of evidence in the pediatric literature, we tried to stay as broad as possible, Emery. We do know that one does not equal another. But formal training, and even that is a controversial topic when it comes to in-hospital certification for POCUS use. And so there was a bleed over between echocardiography terminology and POCUS as well, and that's something that I do want to highlight is a gap still for us because when you think of echocardiography, you think of pediatric cardiologists and or trained echocardiographers. When you think of POCUS, you think of many others who may not be trained pediatric cardiologists, but have facility, competence, and training to do a full, multi, zone POCUS, including cardiac. So we really try to stay as broad as possible.
Yeah, so do we.
Thank you. So we move on to post-ROS care. Can I hand over to Alexis?
Okay, who's the clicker? So as we move into post-ROS care, there's quite a bit in this section, and we've really narrowed to sort of the two hottest topics, maybe the less controversial of what's out there. So you have return of spontaneous circulation in a patient. You're in the ICU, and the bedside nursing team asks you what you want to target for both temperature and for blood pressure. And this is, you'll see, very similar across the ERC and the AHA-AP guidelines. So this was a big change in this iteration. We are now recommending targeting both a systolic and a mean blood pressure greater than the 10th percentile for age. That's a change from the 5th percentile in the last iteration. And then for temperature control, both councils recommend measuring core temperature continuously and avoiding fever. You will see there is a little bit of a nuanced difference at the bottom. The AHA recommends that for comatose patients, we should use TTM to 32 to 34 for either 2 days or 48 hours, followed by normothermia for 3 more days, or you should do normothermia for 5 days.
And we included the temperature control for the first 24 hours in comatose patients and avoiding temperature raises for 3 days. Actually, there's no evidence to support one or the other. It's just more like a pragmatical way to approach one timing or another one from our point of view. So we just kept it simple and similar to what was the before on the adult recommendations. So in summary regarding post-ROSCA, the main change is that we both are supporting to maintain systolic and mean blood pressure about the 10th percentile for age, and I think this is a major change. And we are keeping into avoiding temperature raises and monitoring core temperature without supporting anything further than that.
Thank you. So, I mean, post-ROS care is a huge topic, and for the purposes of this presentation, we've kind of narrowed it down to 2 areas. I will ask one question. You've both agreed on the target for the blood pressure. How have you gone about describing how?
Yeah, we don't know how to describe. We haven't given the recipe to target that blood pressure. So I think it has to be individualized for the patient. It's very, very difficult to give a broad recipe on to whether use vasopressors, whether use fluid resuscitation, on which vasopressor to use. And it's something that we have on our list of to-dos for the next years. And you have it too, Barney, for ILCOR too. So we are looking forward for the evidence on that too, yeah.
Yeah, I think the problem is blood pressure is actually an endpoint of numerous pathophysiologies that are occurring post-arrest. So you have myocardial dysfunction, you have a systemic inflammatory response. How you actually assess that patient, whether you're getting echoes, how you're monitoring end organ perfusion and blood pressure will really help guide therapies. And we do not delineate that clearly enough in the literature that's out there. So it's fluid, inotropes, and vasopressors. It will, I agree, be tailored to the patient. We don't even assess, I think have standardized assessments at this point in time to really delineate how you get to that endpoint of hypotension and what you should do for it.
And just out of interest, because I haven't looked, do you put centile blood pressures for people to refer to so that they know what they are?
We do. We do. We did put some age specific targets for the patients.
Thank you.
I don't think we did.
Okay. We will make sure that we link all the
ERC.
North Americans to the ERC blood pressure targets. Question at the back.
Question about the blood pressure, and also that's at a colleague who was asking me to ask that percentile question also, is why did you stick to age only as opposed to age and height or sex or gender in your recommendation? Because your data suggests that it's varies, so please just...
Yeah, it's a really good question. So if you look at the data that ranges from the 5th percentile to the 95th percentile in height, the difference is within a few millimeters of mercury. When you look across sex, male and female sex, that difference is also not substantial. You could make an argument that, you know, if you go from a 5th percentile female to a 95th percentile male, you'll probably get larger differences. From an implementation standpoint, if we start asking people to get a height, which I think we've been talking about weights today, we can't even get a weight, let alone a height or a length, you're going to really get into trouble from an implementation standpoint. And so this may be that we just want to, come up with a group number. In our clinical practice, we actually don't go by year. We batch ages so that clinicians can say, for a child from this age to this age, we're going to do this. And it will be greater than the 10th percentile. Sometimes it's a little bit higher, but it's really because the differences are not significant enough, and it would be a lot to ask people to implement based on age, sex, and height.
Thank you. Any other questions from the group? And we are keeping an eye on the Slido questions, so if we do have people online that want to add in a question, keep them coming. We are coming on to our nearly final section, and I'll hand back over to Alexis.
Well, this is a really exciting section that we've added. This is new this year to both the, well, I should say expanded for both the ERC and the AHA and AAP guidelines. And I think this is, many of us grapple with this in practice all the time. I mean, this is a big step forward. So the parents of a 5-year-old who's had a cardiac arrest, who's had ROSC and has been cared for in an ICU setting, the parents ask you, what is my child's neurologic prognosis? And how best do we provide that? These guidelines come from a Herculean effort by ILCOR for a neuroprognostic statement that was led by Barney and others to answer that for both a favorable and an unfavorable outcome. And what's come from that for both groups is that you must use a multimodal approach to prognosticate. So 1 measure, 2 measures, not sufficient to make that determination. No single modality can be used in isolation for prognostication, even if they have high accuracy, and that is because the studies that were looked at, nobody ever just used one. And so even if we have something that's highly accurate, you may not use it alone. Both sets of guidelines suggest delaying prognostication for at least 72 hours after arrest in children with decreased level of consciousness or in children who are sedated. And we'll go into our algorithms or our infographics, and I think as you look at that, that'll explain a little bit of why. So first up is the AHA algorithm. You'll see some similarities between these, and that's because they stem from, once again, the ILCOR work. Up top, you're going to see favorable outcome, and on the bottom, you're going to see an unfavorable outcome. This is broken up from day 1 through day 5 to 2 weeks, and there are images and colors that support the different modalities. And I think we would caution people that just because something can be used for a favorable outcome does not mean the opposite of that could be used for unfavorable outcome. You really need to look at these separately, and I think people should sit with these for a bit and look at them. The additional caution is just because you have a measure that may be on this at day 1 before that 72 hours does not mean you should be prognosticating outcome with that alone. It means that it was a measure that may have had some degree of accuracy at that time point. So from a multimodal approach, you're incorporating those factors in as you get to day 3 or later after that 72 hours. But you will see here on this algorithm or infographic that clinical exam in green is pupillary exam is what highlights in both. From a biomarker level, only lactate shows up, no other serum biomarkers. Imaging, you will see MRI further out in both, although CT scan early shows up for unfavorable, and then you'll see some EEG, and you'll have to dive into the guidelines because there's a lot in there. We've also added on the other side of this algorithm what not to use, either because there's evidence against it or where there's insufficient evidence to make a recommendation. And we distinguish those because there are some things we should not be using based on the data out there and some that are limited. And we felt pretty strongly about putting those in because we know these are things that our clinicians are using in practice. So a pH should not be used because it is not reliable to predict neurologic outcome. And we all know that we see 6.6 or 6.9 or 7.1 and people make presumption early on. So be very careful in how you use certain things you may have incorporated into practice in the past. And I'll turn that over to Jana.
Yeah, so that's the beauty of ILCOR, really, because you can see that for the topic that was not really well covered before in our guidelines, we just made it to very similar results. And as you can see, we also have, and that's thanks to Barney, that we incorporated his original ideas about the prognostication for the good outcome and the poor outcome. That's where we stand basically on the same evidence, and we came with the same topics, but we also suggested diagnostic workout with timing that we could use inside the ERC or the European countries, and that's because it can help us if we all use the same investigations, then we can do better studies within the Europe, because most countries can do different things, can do different measurement at different times. But if we have the suggested diagnostic workup with the timings, then we can make throughout the Europe probably one, maybe a registry where we could put those values, and we may be sure that the people will be measuring them at the same time within different countries. About the survivorship, I think this is also a big topic, and that's something that we put a lot of efforts, and we've had the privilege really to have also on board the people whose children either survived or died after cardiac arrest, and that was a big eye-opening moment also for a lot of us to see their moments and their traumas and what's happened to them. And that's why we think very strongly about recommending the survivorship guidelines or the post-discharge care. And it's great that the AHA came to the same conclusions. I must say that the psychological, cognitive, and emotional morbidities should be measured after cardiac arrest and addressed through multidisciplinary rehabilitation services. So I hope that will be also a standard of care within the Europe and within the US and in other countries for better outcomes of our patients, and not only patients, but also our families of the patients and their loved ones. For the ERC, we also came with this infographic where we tried to put all things that might be in pediatric post-discharge care that might be important into this infographics with the recommendation for caregivers, cardiac arrest survivors, for systems, and for healthcare professionals. And we feel that only by putting it into the common thing that we can achieve the better outcomes for our patients. So we have to think about our survivors, but also about their caregivers. We have to screen them for the signs of, for example, pediatric intensive care syndrome, family signs, and we have to also think about the systems, because sometimes we might be very keen about putting in some post-discharge care, but if we do not push it on the systematic level within the healthcare systems, it might be very difficult for a single healthcare professional to do something about it. So gathering data and also pushing the really good registries, really good outcomes data on a system level, that's what we feel is important.
Thank you. So just before we go on to knowledge gaps, this is a huge area. ILCOR and the team backed me up to start to work through the evidence evaluation to really try and tease out accuracy, what we should be doing, and some guidance. The guideline groups have taken that on, but we're still not yet there with a kind of clear algorithm to actually say, do X, Y, and Z and everything will be fine, or do A, B, and C and we need to be worried. But we're at least getting closer to give guidance about when things shouldn't be used or when it should be used. One issue that you kind of links the two things together, of course, the neuroprognostication data often is predicting outcomes which may only be, do they leave hospital or do they get to 1 month? Some of them are a little bit longer, possibly a year. Survivorship, of course, is a lifetime issue, and in pediatrics, that's the longest life we can offer a child if we can get them through and to maximize the survivorship. So I just wonder between the two where the groups think the future needs are in this area when it comes to the kind of guidelines, if we're thinking forward for the next 5 years, particularly in the relationship of how you link the survivorship data and this push to understand and support survivors, and then feeding that back to actually, although the neuroprognostication information within an ICU in the first few days may be important, actually that may not be relevant to how the survivors continue as they're going months or years down the line. They're not going to worry what the pupil response was on day one. They're going to be wanting to know, have I got home? Have I got to school? Can I sleep well? So I just wonder a kind of open question about whether we've come a distance, and perhaps whilst we're here in Rotterdam, the team, the kind of groups within the hospitals here are probably leading the way to try and help pull us through this area. But a kind of call to arms, what would you like?
So that's a pretty large question. I think the first thing is we've got to get some standards outcomes for neuroprognostication, and we need to look beyond hospital discharge, and we have to start being able to look at studies that we can combine together in a multi-center way. I think families don't want a child that is necessarily going to only have an outcome at 1 month. They want to know what the long term looks like, and currently we have no way of giving that to people. Additionally, we need to determine, and I think some of this work is happening, is will children grow into their deficits or will they grow out of their deficits? And children, unlike adults who have a cardiac arrest when they're young, may continue to develop and thrive. And so these early outcomes are actually not what are meaningful to parents. They want a child to survive. We heard that from them when we did the PCOSCA statement, but they want to know what their child's going to look like in the long term. And so when we're neuroprognosticating, once we've figured out the survival piece, we need to figure out what long-term outcome looks like, and we need to start thinking about what favorable outcome looks like, not from what a researcher thinks, but from what a family thinks. I think that will all tie into survivorship, because survivorship is not living long, it's living with quality. And until we can help guide families as to what long-term outcomes look like for their children and prognosticate in that way, it will be very difficult for us to talk about survivorship in a shared language between researchers and families.
And I'd like to add that I think that they both link perfectly well, because once you start looking into survivorship, that enables you to try to help families who are in step one of this road towards survivorship, so in day 1 and day 2, to confront what they are going to go through in the next days, months, and years too. So I mean, knowing what they're going to face because you've gone through that with other patients helps you ease the load too in those first days.
I'd also like to add that in reviewing the literature, it was pretty shocking at how little patient-reported outcomes are available currently for this population. And so when you're looking at patient-reported outcomes, that is a whole nother beast to tame when it comes to research because of the resources needed to follow patients, track them down, and then how do you convert qualitative data into quantitative data to understand. And so this is, again, another call. And especially, you know, I'm going to be pointing right now at the NIH in terms of their distribution of current research funds in regards to pediatric literature and pediatric research. And you know, there is a lot going to pediatric cancer research right now, but we need just as much for post-arrest care. And so I think especially the resources needed to try and understand patient-reported outcomes, which are lifelong in this case.
Thank you. Are there any questions in the room? So we've kind of summarized some of the knowledge gaps. So these are declared by both ERC and AHA, and they're kind of throwing the ball back to ILCOR to say, fill in some gaps. And my request is from the kind of evidence evaluation. I can only evaluate evidence if the researchers, the communities, the young investigators out there are going out and trying to find these questions. So this kind of summarizes some big issues that we haven't quite pinned down, and some of them we're a long way away from pinning down. Age differentiation is a great question. We have our neonatal colleagues in another room talking about newborn resuscitation, and those neonatologists in those settings will use some of that neonatal life support approach. And when does our pediatric algorithm kind of need to step in? And there's overlap and that kind of NLS to PLS transition is a really important question that we're working through. And then, of course, as the little kids become bigger kids and then they start to become adolescents and grown-ups, hopefully, no one quite knows when that transition is, and particularly from a resuscitation physiology point of view, when an algorithm which is written for children, and predominantly younger children, should transition to the adult life support approach. Ventilation and the way that we're actually delivering, we all agree that respiratory kind of correction, ventilation breaths are essential within the kind of pediatric algorithm, but actually understanding whether it's pressure, whether it's volume, the pressure to deliver the rates that are given. And so teasing out that evidence to try and help guide what is a one-size-fits-all type approach at the moment is important. We've talked quite at length about adrenaline and some of the kind of nuances about timing and about dose and those differences, and trying to tease that out along with shocks, both the level and the amount and the dosing of the defibrillation dose. CPR quality, really proud that the pediatric researchers and the literature are kind of leading the way and pushing to our adult colleagues and our neonatal colleagues that there is a lot to be gained by physiological feedback about individual patient care, about that kind of individual knowledge, but really working out which are the key elements. If you're going to increase resources and buy devices, which ones are going to give you the best kind of value for money? And the post-resuscitation field is huge. There are gaps that are still there, both even the kind of ongoing conversations about temperature management and how we do it, and whether there are specific populations and stratifying patients to the correct care are gaps that we're looking for in the future. So I put this summary slide up. These are the elements and the kind of high-level information that has been shared with you in this session. It shows both the similarities between both the AHA and the ERC. It shows the huge amount of information, even within this small topic, this small kind of area within pediatrics that has been covered. I'm going to allow the next slide, and we can come back to this one for questions, but I just wanted to allow, certainly from an ILCOR point of view, I'm one of a huge team that looks at the evidence, and although I haven't listed them up here, a lot of them are in the room here with us, and a huge thank you. All those emails, all that effort, all that time, all that intellectual input, all that debate, all the understanding and the pushing the researchers, that's where at least the evidence starts from. But I'll hand over to perhaps Javier next.
So yes, I think this slide right here is a call out to our writing group and to the many staff members that we couldn't have done this without them. Really tremendous effort from the AHA and the AAP teams as well. Melissa, I know you're listening. Thank you, Shalana as well is here, and Jessica for all your work, hard work. And this being the first year that the AAP and the AHA have combined, being a co-authoring has been a great support for us in terms of being a liaison between the two groups. Again, Gary, John, Jen, Ariel, Taylor, Ryan, Joan, Kat, Todd, and Santi, thank you guys. We can't wait to celebrate. Hopefully see each other at REST in New Orleans.
And for the ERC, of course, the same is true. We couldn't have done it if we didn't have a really amazing team of people who were doing the work and really looking at all the questions that we were asking and looking at the evidence, and then building up the guidelines. And of course, the ERC staff who then supported all our meetings and also helping us with developing the algorithms, the pictures, and all the additional materials that you can find within our guidelines. So thank you a lot.
So thank you. We've just got a couple of minutes if there are any final questions in the room. We have a couple of questions on Slido, which I think Aditi is going to read out for us. So we want to make sure that they are addressed.
Thank you very much. So the first question I have is, how do you suggest approaching young children with obesity who have adult weights?
So basically in the ERC guidelines, we say you use the length-based materials that are adjusted for the type of your body. Like if you are underweight or overweight, then it is adjusted. There are some, like a Pauper-Mac length-based method. So that's one point. And then if you get to the 50 kilos, you probably, in most topics, you just switch to adult dosing. So that's just what we have in the guidelines, mostly. Yeah, and it's covered in our guidelines.
So we have not touched on obesity specifically in our guidelines. That being said, it's, I think, something that North American providers are faced with on a daily basis. I think you kind of need to think through this in terms of providing CPR and what that looks like. So some of the quality metrics may be helpful, especially when you're looking at blood pressure, potentially end tidal. That actually really gives you an output of what you're putting in, and that may look different. We don't know for children with obesity. Medication dosing is something that ILCOR is working through. Optimal dosing based on weight is still something that needs to be sorted out and how that impacts clinical outcomes. But I think the most important thing is that when you have a patient that is outside of your bell curve of the norm, you have to think about, while you're using standard resuscitation, do you need to think about things specific to their condition that may impact their outcome while using the standard guidance that we provide.
Thank you very much. I have another question that I think is more for our AHA colleagues. And it says, if you already have IV or IO access before having or identifying a shockable rhythm, is it still suggested to wait for the second defibrillation before giving epinephrine?
For a shockable rhythm, we would still recommend, even if you have an IV or IO in place, to shock first and then give your epi. Absolutely. We do have a question in the room, maybe as a follow-up for the obesity question, is that? No. Okay.
Hi, Farhan Banji from McGill University, Montreal, Canada, Heart and Stroke Foundation of Canada. That was a great presentation. Really liked it. I really liked how you put that together as well. It wasn't just about the knowledge and disseminating that, but how you captured those differences and really put that out there. So congratulations, really absolutely fantastic job. Just a question and a thought, and this is putting my ILCOR hat on. Do you think that there's any possibility for us to start to think about treatment recommendations that might actually span the globe? And the reason that I bring this up is you highlighted some differences there, but they were not differences that were decided based on the environment of Europe versus North America. And they were not differences that would persist. It was differences that likely are related to the 10 people or 13 people and 12 people that were in the room. And if you changed around those 12 or 13 people, they might have gone a different way in both of those different areas. And I wonder, and I'm throwing this out there, is there any possibility to say, how could we come together, and even though we're in, localize things when it's important to localize, but try to come to some sort of agreement when we can? And if we can't, what's our mechanism for looking at natural experiment data? Yes, it's not randomized controlled trials, but to look at that to then guide future practice. And is there any possibility to think along those ways? Barney, you're welcome to jump in too, because I think that's sort of a bigger picture theoretical thing, but I just loved how you presented and put your thoughts out there. So I'll ask you that 30,000-foot question.
Jana and I actually just had the same conversation over lunch.
Sorry then. You guys have already figured it out.
We have not figured it out. But I think, for the dreamers in the room and the idealists, the idea that we would have an international set of guideline recommendations for how to do CPR for children and take care of them through the peri-arrest spectrum is where we need to be as a global society right now. But we are bumping up against several challenges, which I think are quite obvious. I hope that the message from today's presentation was that we are more aligned than not. So I'm getting nods in the room, and I think that's most important. So when we're talking about international guidelines, we have to have that space for some deviations, right? Correct. We have to recognize that we're going to have some deviations that might be situational or sort of culturally unique, resource limited, et cetera. But there's more that we can probably join forces on than not. So how to do that is not the 30,000-foot question, but in the trenches question. And I think it's going to involve a heroic full-time, actually 2 times full-time job from volunteers and or from the organizations. And I think, hopefully we can get there. Again, we just started the conversation, but I'd be curious to hear from others in the panel, as well as in the audience, about sort of how you guys might see that happening. But first, panelists and Barney.
No, and I think I totally agree with you, Javi. But I think that that was one of the reasons that we wanted to include this knowledge gap slide too, so that we were keen on emphasizing that we got more things in common than differences when interpreting the literature or trying to implement those data in our media. But then that we are raising the same questions, and that we want to launch those questions to the scientific community, because we are the first but not the last to need those answers too, and taking care of our patients on a daily basis. So I think putting that slide together is like a flag, raising a flag and saying, okay, we need all your help, and we need all your help to put all the information, all the data from our patients together, so we can answer globally those questions.
And my only comment is, having come from the UK working under the ERC guidelines and now being in Canada working under the heart and stroke guidelines, I've been relieved how kind of closely aligned they are from a clinician point of view. However, the reason why we like to find that there are still differences, and this conversation has allowed those to be brought out for a number of different factors, is that we may also not have it right yet. There's a lot of improvement and iterative improvement, and sometimes seeing how things work slightly different in a different system, and it's that system and implementation, and then the kind of delivery of the kind of algorithms or the elements of the resuscitation that allow us to then question and go, you know, we need to look and find out why that little subtle difference. Does it make a difference? Does it just work better in one place, or is there science behind it? So to be a global doctor and to run around different intensive care units around the world, or different emergency departments, and speak the same language, that's, one want. But at the end of the day, we want to make sure that the child in the country and the setting is getting the best level of care, and the resuscitation councils of each of those regions has the best insight, and the local resuscitation councils understand their concept. And if that does mean that things have differed from the original science that is presented, and it's been looked at in a sensible way, then that still has to be the best thing for the patient. So it's kind of a goal to say, if we're all the same, then we've answered the question, and it's, we're doing the best that we'll ever do. But I think the way that we have it means that it keeps us fresh. It keeps us looking forward to have these conversations, to go, why is that a little bit different? Is there one that's better? If there isn't, what else can we do to tweak and understand that?
I just wanted to add that you could see that for several questions we were able to get to the same level, and that's basically those that do not have this historical package behind them. Yeah.
That's exactly my point.
So,
baggage and culture who's in the room, not any science.
yes, but the historical, it's already there. So we are carrying it, and it's difficult to say now we move to something completely different if there is not like a really, really strong evidence towards it.
But it's all a reminder to the funders and to the researchers that although it was how you were taught 20 years ago, we still haven't got the answer. So there's still questions that need to understand. I'm going to let Ryan, definitely let Diane have the last question. And then
I'd like to provide a little history, because I think I've been with ILCOR longer than anybody else. I don't know about, let me see. Probably from the 2000s, early, 2000. When ILCOR was being developed, that was the goal, was to have international guidelines. And it became fairly apparent quickly that that was going to be very difficult to achieve at that time. Now, we are 30 years beyond that, and a lot has changed. ILCOR has facilitated much greater conversations among all of the resuscitation councils, and I think that's evident here, especially with AHA, AAP, and ERC. The other thing we have to think about, well, the other thing that has facilitated this is our ease of communication. But in the late 90s, our fastest way to contact people was fax, and maybe some email. But we certainly didn't have the internet, which was as developed as it is now. We didn't have cell phones that we could get anybody anytime. So a lot has changed, and it's well worth thinking about. But I would also say that you're looking at AAP and ERC, which have a lot of similarities, both in terms of the cultures that they have developed for medical care. But as we extend to larger parts of the world, especially with lower resource settings, the ability to have international guidelines becomes much, much more difficult. So I'm not saying that it's not worth thinking about, because there's a lot has changed and we may be able to do it. And that was the original intent. And when we realized that that was not going to work, we evolved into the science review and then letting individual councils, based on their culture, develop their own guidelines.
Thank you. This brings our session to a close. I just want to thank the four panel members and everyone that they represent in the background for the fact that we have such an amazing set of guidelines to present today. Thank you to the audience for your participation. Thank you for those online. There will be plenty more questions and discussions as you read through what are two amazing documents with information that we hope is going to save children's lives, improve outcomes, and lead us through for the next few years as we continue the research to try and make them better, to make patients better, and to make outcomes better. So thank you all very much. Please give a big round of applause to our speakers. Thank you.